So welcome to everybody. Great to have you here at very different times of the day, I think, over the world. Very grateful for the guys in New York organizing this. The session today will be about modulators of tDCS effects of quite different origins. So we will have some pharmacological studies, some chronotype stuff, and also titration studies to explore how all these effects affect plasticity, which is induced by tDCS. Talks will be given by PhD students of my group. So welcome to Lorena, Elham, Ali, Mohsen, and Desmond. Very great that you're doing the talks today. Duration of the talks will be about 20 minutes each talk. I put the timeline in the chat. We will have time for questions afterwards. You have two main options, so we can unmute you, so you can ask your questions orally, or the other option is that that you post the questions in the chat, and I read them then for you, and we will answer them then. And yeah, welcome again, and I think we can start now with Lorena DeMelo's talk about the impact of serotonin on tDCS effects.
Hello,
all right.
everyone. Okay. Yeah,
Yep,
it's
perfect.
okay.
Perfect.
All right, so let's start. So good afternoon, maybe morning and different times. I'm Lorena DeMelo, and I will start this session talking about the impact of serotonin on tDCS effects. First, I just want to show you my goals with this presentation. I will give you a very brief background, then talk about some previous studies, part of my preliminary results, and some closing remarks. The serotonergic system is involved in a huge variety of functions like memory, learning, cognition, emotions, mood, and so on. And this huge amount of different functions and also the complexity of the serotonin system help us to understand why this system is the focus of so much attention in the research community. But what does low serotonin feel like? Some examples are high levels of anxiety, low self-esteem, mood swings, and depression. We know that selective serotonin reuptake inhibitor, SSRI, can enhance serotonin levels, and citalopram is a highly selective and potent SSRI with minimal effects on the neuronal reuptake of norepinephrine and dopamine. Some studies with humans and animals have provided some evidence about the role of serotonin in modulating or affecting LTP and LTD-like plasticity. And pharmacologically controlled changes in cortical excitability might be beneficial for synaptic plasticity. However, the interaction between serotonergic activation and neuroplasticity need further and deeper investigation. We all know that with tDCS, we are able to induce brain plasticity. And so far, some studies, actually a few studies in the literature, have shown that when we enhance the serotonin levels and we combine it with tDCS, we can affect motor cortex plasticity. So the first study in this field was done by Professor Nietzsche and colleagues in 2009. And they aim to explore the impact of citalopram using 20 milligrams on plasticity induced by tDCS, sorry. Here I will show you with a little bit more details the design because it will be helpful for the next slides. So the main, the outcome measure here was difference changes in cortical excitability. So first of all, a baseline were recorded using single pulse TMS, recording MEPs. Right after, citalopram or placebo medication was given to the participants. And around 2 hours later, a second baseline was conducted. And if necessary, a third one was performed. If they needed to adjust the TMS intensity, so a third baseline was performed. After the second or third baseline, tDCS was applied, anodal and cathodal tDCS. And when citalopram was combined with the tDCS, the plasticity was monitored up to the same evening after intervention, meaning around 6 to 7 hours after tDCS. And when placebo was combined with tDCS, the excitability was monitored up to 2 hours after intervention. The first part of the result, here you can see the results for anodal tDCS. And for this graph and the following, you can see in the vertical axis, MEP's amplitudes, and in the horizontal one, the time points. So here you can see the effects of citalopram plus anodal tDCS, and here the effects of placebo. And what happened, citalopram increased and prolonged facilitatory plasticity induced by anodal tDCS. The results for cathodal tDCS, it's here. You can see here cathodal plus placebo, and here cathodal plus 20 milligrams of citalopram. And under citalopram, it converted the inhibitory plasticity induced by cathodal tDCS into facilitation. Some years later, Q and colleagues in 2016 performed a study to investigate the chronic application of citalopram. Again, using 20 milligrams on the plasticity induced by tDCS. In this study, they had two parts. The first part was a placebo control, and you can see the design is very similar to the one that I just shown you. First, baseline MEPs, then placebo, because this is the placebo control. The baseline 2 or 3, anodal tDCS was applied, and in this study, the cortical excitability was monitored up to the next evening after stimulation, meaning more than 24 hours later. The second part was the chronic application of citalopram, and if you have a closer look in the pill intake, you can see that the participants were under citalopram effect, and in a randomized order, they received placebo. So the excitability could be monitored just with citalopram effect. And in this study, they also added DMO, that it's dextromethorphan, NMDA blocker, and applied anodal and cathodal tDCS. And again, for the second part, the excitability was monitored up to next evening after stimulation. Here, the first part of the result, in the first graph, we can see anodal tDCS results. And again, the excitability was increased and prolonged. And here it was prolonged more than 24 hours. And for cathodal tDCS, here again, cathodal and placebo, and cathodal plus citalopram, it converted the inhibitory plasticity induced by cathodal tDCS into facilitation. For the association with citalopram, DMO, and tDCS, here you can see the results for anodal tDCS and citalopram. Anodal tDCS, DMO and citalopram. And in this graph, you can see the effects for cathodal tDCS. So when they add the NMDA receptor block, it abolishes serotonin-dependent tDCS induced plasticity enhancements. So later, some studies now with patients, they combine the SSRI with tDCS again. But here they used the stimulation in the prefrontal cortex, in the DLPFC, and the patients were depressive patients. And this combination of tDCS and SSRI was able to decrease this Montgomery Asberg depression scale scores. So the first summary here, what we can say, citalopram using 20 milligrams, it increased and prolonged facilitatory to plasticity induced by anodal tDCS. It converted inhibitory to plasticity induced by cathodal tDCS into facilitation. And the impact of citalopram on tDCS appears to be NMDA receptor dependent, as DMO plus citalopram abolished tDCS after effects. And studies with patients revealed promising results for the SSRI and tDCS combination. However, we still have a lot to understand. We still have a lot of questions, especially about the mechanistic aspects of this combination. And during my PhD, I want to investigate more about this association. And in my first study, my first question was what happens when serotonergic activation, when we have this serotonergic activation with different doses in healthy individuals. And my goal was to explore the dosage-dependent effect of acute serotonin enhancement on excitability changes in the motor cortex. So I conducted a crossover design with 12 healthy participants, and it was 7 sessions. The design you are already familiarized with. So first of all, MEPs, baseline 1, then the participant received the pills, 20, 40 milligrams or the equivalent placebo. Again, 2 hours later, the MEP was assessed again, baseline 2 or 3 if necessary. And after tDCS was applied, and here we added sham tDCS plus placebo, and the excitability was monitored up to same evening after tDCS. So my first result here is for anodal tDCS. In gray, you can see sham tDCS plus placebo. Here you can see in pink anodal plus placebo, in red, light red, you can see anodal plus 20, and in darker red, you can see anodal plus 40. And in general, what we found is when we added the drug, when we added citalopram, the excitability was increased and prolonged up to same evening after stimulation, but there is no difference between 20 and 40 milligrams. Here you can see the results for cathodal tDCS, plus placebo, light blue here, cathodal tDCS plus 20, and darker blue, cathodal tDCS plus 40. And here we could see that this switch in the cortical excitability after effects for cathodal tDCS were prolonged, but only when 40 milligrams was added. So what we can say after this. Anodal tDCS after effects were increased and prolonged while cathodal tDCS after effects were switched to facilitation. And with my preliminary results and also with what we have in the literature, we can say that this is true for acute or chronic association. In my study for anodal tDCS, the effects were prolonged regardless the dosage. And for cathodal tDCS, the switch to excitability enhancement was prolonged only with 40 milligrams. And so what we can say about the impact of serotonin in tDCS effects. First, we can say that serotonin has a prominent impact on plasticity in humans. At a group level, 20 and 40 milligrams have largely similar effects on cortical excitability. And despite a single dosage of SSRI has usually no significant clinical effects, SSRI might be useful to strengthen anodal stimulation in treating patients. And if we go a little bit further and think about evidence-based practice, as scientists, we need to produce and to investigate more about this association to be able to help the clinicians and the patients. Thank you.
Okay, many thanks, Lorena. Great talk. So nobody can really clap now, so it's all virtual. And yeah, quite well in time also, and received already a couple of questions. There's a question from Dr. Baker, and I just read it for you. Do you think that a patient with a history of taking SSRIs but who is not currently taking them would influence effects of tDCS? In addition, did you notice any of your subjects suffering from serotonin syndrome?
Okay, first of all, I can tell that none of my subjects suffered from serotonin syndrome. It was acute application, and despite moderate dizziness sometimes and nausea and sleepiness, it was nothing else. And well, I think it depends on how long the patient took the SSRI and how long he stopped. So if it was like some months ago, I don't believe that it can influence. But what do you think, Professor Nisser?
Thank you.
Okay, many thanks for answering this. Then we have a second question from Elham Ghanavati. And the question is about enhancement of effects. It's great to witness. Can you comment whether MEP variability reduces as well?
Well, we have some participants that they respond more, and the ones that they respond kind of less. But I'm not quite sure what you mean about if the variability reduce.
I think what is meant is MEP to MEP variability. So if it's getting more stratified or something like this.
Yeah, I'm conducting some further analysis to investigate this variability. I dividing some participants in their response, their MEP responses, and also trying to correlate the MEPs, the response for tDCS with some other variables like chronotype, like the weight, the body mass index, but I'm still working on it.
And I think maybe if I could add, it's a bit tricky because you have some intrinsic variability of MAP responses due to simply methodological reasons, because you don't have a completely synchronous action potential delivery from the cortex to your muscle. And for this, it's very tricky to imagine that this could be stratified, or the variability could be largely reduced by it. So you will always have a kind of variability of MAP amplitudes. But what I could think of is, because SSRIs make you a bit more awake, also dosage dependent, but if they enhance wakefulness, you have maybe less problems with people getting tired with experiments or something like this. Not.
I don't believe. No, I don't think
everybody
so.
gets tired after 2 hours measures. Okay. Many thanks again. I can't see any more questions currently. So for the audience, that's your chance. Also, if you want something more to ask, you still have some minutes to start with the next talk.
Nothing else, I think.
So nothing currently. So we could. I mean, question is how I had the time plan in the chat before.
Okay, that there is
so we
one.
Still would have some minutes, but I have also the feeling there might be some talks which might be 2-3 minutes longer. And since we didn't fit to the minutes in the plan, I think we can continue now with the second pharmacological talk. Many thanks again, Lorena.
You're welcome.
And we go on with Elham, and she will talk about the impact of dopamine on tDCS effects. So we should unmute Elham.
Yeah.
Can you hear me?
Yes, everything fine. I can hear and see you.
So, do you have my screen also?
Not so far.
Okay.
Maybe until you start, we have another question now for can spare time. Another question for Lorena now from Dr. Baker, who asked that do you think we should be more exclusionary for people with depression in our studies?
Yes, I think so. Especially if you are working with healthy participants. So it's very important to do this screening and exclude any psychiatry or psychological conditions. I think it's really important.
Would also agree. I think it depends on the group. So if you want to work with health subjects, then it's important that you don't have depressed subjects in your group, also because we know that they have altered plasticity, so they might have altered efficiency of tDCS. When you are aiming to treat depression, then it's, I mean, there's a couple of studies which were quite successful, especially with the combination of SSRIs also and of tDCS. So this should not be a problem. The other way around, combination might help.
Yeah. Okay. So
no more questions. Then we change now from serotonin to dopamine to make things a bit more complicated.
Yes.
I think Elham, if you want, you can start.
Okay, you have my screen, right?
Right.
Okay. Okay, hello everyone. I hope you're all doing well and healthy during this challenging time. I want to first say thank you to the organizers of this really interesting conference. It's a good opportunity to get the most out of our time right now. So the topic that I'm going to talk about today is part of my PhD project that I am currently doing in a Leibniz Institute in Dortmund, Germany. So in this experiment, we wanted to take a look at dopaminergic modulation of tDCS-induced neuroplasticity, but with regard to the specific contribution of NMDA receptors and the role that they play in this scenario. So we know that the precise understanding of dopaminergic system is crucial in terms of diagnosis and treatment, the neurological and psychiatric disorders that are related to this dysfunction of dopaminergic system. And also for understanding the basic neuronal processes that are related to dopaminergic system, like learning and memory. Animal studies suggest that these impacts of dopamine on brain physiology in general could be as a result of the modulation of dopamine on long-term potentiation and depression. If we want to explain it in a very simple way, dopamine has two groups of receptor subtypes, D1 group and D2 group, that they usually have different functions. D1 receptor subtypes usually potentiate the activation of NMDA receptors, and as a result, we will have more calcium concentration. And this process usually leads to the induction of long-term potentiation. On the other hand, D2 receptor subtypes have usually an inhibitory and suppressing impact on NMDA receptor and calcium concentration, which can lead to the induction of LTD. So if we want to investigate about the specific neuromodulators and their role in the human brain, we can combine pharmacological interventions with non-invasive brain stimulation techniques that we can actually induce neuroplasticity or monitor excitability. tDCS is one of these non-invasive brain stimulation techniques that we already, I think you already know about enough. Just a quick overview, tDCS modulates cortical excitability by a weak and diffused current over the target area, and after effects differ considering the polarity, intensity, or duration. But one point that I specifically want to emphasize here, and it's important for interpretation of our results, is that the tDCS generated after effects are suggested to be NMDA receptor dependent. A pharmacological study with dextromethorphan, which is an NMDA antagonist, showed that applying this medication actually abolished the after effects of tDCS, both cathodal and anodal. On the other hand, in another study, we see that D-cycloserine, which is a partial NMDA agonist, prolonged the after effects of anodal tDCS. So what we know about the impact of dopamine on tDCS-induced plasticity. Montesilva and Minfang Ku found that administration of 100 milligrams of L-Dopa, which is a general dopamine agonist, have an overall inhibitory impact on tDCS-induced after effects. Where we can see here the cathodal after effects of tDCS under L-Dopa prolonged until the next day, while anodal tDCS, actually they're converted into this excitability diminishing effect, which is something that we were interested in our project, and we wanted to find out about the mechanisms. So as I mentioned, the role of dopamine receptor subtypes are important. Here in this figure, which is not very precise, by the way, I just wanted you to have a rough idea. I summarized few studies of our group that they investigated the role of general dopamine activation here in orange, D2 receptor, and D1 receptors. Here we have the results just for anodal tDCS. So the first thing that we can see is that is the clear dosage-dependent and nonlinear impact of dopaminergic agents, where both low and high dosages of these substances impair plasticity, which is similar to the impact of dopamine on cognitive functions, where we have this inverted U-shaped response. And the point that is interesting is that medium dosage of D1 receptor activation actually preserve the after effects of anodal tDCS, while both general dopamine activation and D2 agonist activation actually prevented or converted the after effects of anodal tDCS into inhibition. So based on this, we might be able to suggest that the global dopamine impact on tDCS-induced after effects is largely mimicked by D2 receptor subtypes activation and their suppressing effect on NMDA receptor. So for our experiment, our aim was to explore more about the NMDA mechanisms involved in dopaminergic modulation of tDCS-induced LTP-like neuroplasticity, and also to take a look at the possible dosage-dependent effects of NMDA receptor activations as well. So here we have the course of our study. It was a placebo-controlled, double-blinded design experiment. We started our experiment with recording our first baseline with single pulse TMS motor evoked potentials that we used for monitoring excitability changes. And after that, we have our pharmacological interventions, which is a little bit complex because we had two groups of medication. One group, we call it dopaminergic group. We had L-Dopa for general dopamine activation. We had bromocriptine, which is a D2 agonist, and we had placebo. And also in combination, we had 3 different dosages of D-cycloserine and also placebo. So this medication actually, when we combine them, we had 12 pharmacological conditions. So each subject goes through 12 sessions. After our pharmacological intervention, we wait for 2 hours for the medication to reach their maximum concentration in the plasma. Then we have our second baseline with still TMS MEPs to actually look at if there is any changes that is the impact of the medication. And if needed, we readjust with the third baseline. After that, we induced our plasticity with anodal tDCS for 1 milliamp and for 13 minutes over the left motor cortex. And immediately after the end of tDCS, we have post-tDCS measurements with TMS MEPs every 5 minutes up to 30 minutes, and 60, 90, and 120 minutes, and also the same evening of the experiment. So here we have the results. I divided them into 3 groups to be easier to explain. Just have in mind that we just had 1 group of participants going through the experiment. So the first we have the impact of D-cycloserine alone on tDCS-induced induced LTP-like plasticity. We call it D-cycloserine alone because it's actually a combination of different dosages of cycloserine and placebo. So as you can see, in pure placebo condition in gray, we have excitability enhancement up to 1 hour. When we added low dosage of D-cycloserine in red, we still have excitability enhancement. There is a trend of reduction, which is significant in just 2 time points. And adding high dosage of D-cycloserine in yellow, you can see that the after effects of anodal tDCS are completely abolished. And when we added medium dosage of D-cycloserine, you can see that the after effects of anodal tDCS actually preserved and prolonged, and we have significantly a higher excitability in the late time points. So the second group, we have the combination of L-DOPA, a general dopamine agonist, and different dosages of dicycloserine. Here, just have in mind that we consider L-DOPA and placebo combination as a baseline, and we compare other 3 conditions to this one. So in gray, we have pure L-DOPA condition that actually converted the after effects of anodal tDCS into inhibition. And when we added 50 milligrams, which is a low dosage of dicycloserine in red, you can see that the results actually didn't change. And when we added high dosage of dicycloserine in yellow, we have a little bit excitability enhancement, but the after effects of anodal tDCS are still abolished. But by adding a medium dosage of dicycloserine in green, you can see that we could reestablish the after effects of anodal tDCS. That is actually the excitability is significantly higher in all the time points. And finally, in the last group, we have D2 activation. So here again, we consider the combination of bromocriptine, which is a D2 agonist, and placebo as our baseline, and we compare the other 3 conditions to this one. So in gray, bromocriptine D2 activation actually abolished the after effects of anodal tDCS. When we added low dosage of dicycloserine, we still see abolishment. Adding high dosage of dicycloserine in yellow, you can see there is a little bit of enhancement in the beginning, but still the after effects are abolished. By adding medium dosage of dicycloserine, we can see that the after effects are reestablished, and there is excitability enhancement that is significantly higher in most of the time points. So if we want to summarize, we have the pooled data of all 12 conditions here together. The first point that we can conclude here is that it seems that dicycloserine has a dosage-dependent effect on dopaminergic modulation of LTP-like plasticity, where medium dosage of dicycloserine reestablished the after effects of anodal tDCS that were originally blocked by our dopaminergic agents. And this effect can be caused by enhancement of NMDA activation and optimal calcium concentration with medium dosage of dicycloserine. Low dosage of this substance actually seems to be not just sufficient to induce any changes in the after effects. And with regard to the high dosage, we saw in all 3 groups that the high dosage of dicycloserine abolished the after effects of anodal tDCS that can be caused by calcium overflow. We might be able to actually explain it with this model of no man's land that Lisman and colleagues developed, where although a moderate amount of calcium is necessary for the induction of LTP, too much calcium will actually lead to overreaction of the system and results in antagonistic mechanisms where there is no clearly directed plasticity, as we saw in our results with administration of 200 milligrams dicycloserine, which was apparently too high. And last point that I want to conclude is that D2 receptor reduction of NMDA activity seems to be relevant for the impact of dopamine on LTP-like neuroplasticity, because both dopamine and the general dopamine and D2 activation actually prevented the after effects of anodal tDCS, but when we added a medium dosage of NMDA activation with dicycloserine, we could reestablish the after effects again. So that was it for me. This is also our group that I am lucky to be part of, and thank you. If you have any question, I will be happy to answer. I think I finished earlier than 20 minutes.
You're all very fast. Yes, many thanks for making this complex experiment well understandable, I think. Okay, so we are open for questions. Currently, I don't see any questions here.
Michael or Elham, I had a question.
Yeah.
Okay.
I'm very interested, and I know it's been developed for a while, this how cathodal pushes you up into LTD, and then nodal pushes you further. And it's almost as if, you know, when we think about firing, we think of a nodal as excitatory and cathodal as inhibitory. But actually in this model, they're both kind of pushing the system in the same way. Cathodal is just weaker. And if you, right, it seems like the cathodal is also a up, more calcium, and they're both pushing in the same direction. Is that one way to think about it? And just that cathodal is less effective at pushing up than nodal?
I think that's tricky because you would then expect that with low intensity anodal tDCS, you would get also an excitability diminution, which we didn't see so far. One option to explain this would be that you have most probably have a pre-postsynaptic effect. So to induce plasticity anyhow with the stimulation, you need presynaptic activity. In a silent slice, you won't get activity. And so one opportunity would be that if you have postsynaptic depolarization of your critical compartments of the neurons, and presynaptic you have some afferent activity, and this combination might affect what kind of effects you get. And I'm not quite sure if you have even the same exactly the same neurons you affect, especially for the presynaptic effect. So it might be that you have differently directed neurons, you have different effects for. It's something which is very tricky to explore, of course, in humans, because we don't have, we cannot do really cellular experiments there. But this would be one way, I think, to explain this, because I mean, we see also nonlinear effects with anodal stimulation, but if it would be simply this linearity effect in a way, then with low intensity we would get antagonistic effects which we don't see. So I would think this might be partially different parts of different populations of neurons, especially afferent populations of neurons, which you might affect. Okay, now we have some questions. We have a question from one question from Rosina Gregoret. I hope I spell this correctly. And question is here: what are the effects of dopamine on SICI, short latency intracortical inhibition, and ICF? So can you say something about this?
On CK and ICF, the effect of dopamine on CK and ICF? Yes, as far as I remember, actually, I don't remember very clearly, but we had a study in our group that they actually investigated the impact of dopamine on brain excitability using CK and ICF. But I'm not clear right now about the results. Can you help me with that, Michael?
So what is known is that, for example, in Parkinsonian patients, one of the most consistent effects is they have reduced SICI, which also makes sense because you have so D2 receptors, which are predominant in the motor cortex, reduce not only NMDA receptor activity but also GABAergic activity. So and if you add dopaminergic medication in these patients, you get an increase of SICI. Human experiments, you see the same tendency, but results are a bit more mixed. so I think you get similar effects for SICI. So you get increase of SICI with dopaminergic medication, but for ICF, where you would expect, due to what we have shown, glutamatergic enhancement, so increased, reduced this dopaminergic medication, global dopaminergic medication, you would expect reduced ICF. It's not so clear for this protocol. And we didn't do this in our experiments here. Okay, then we have another question from Dr. Salimpur. Question was here, based on these results, what montage are you recommending for Parkinson's disease study? Anodal on the affected side or reversed?
So for Parkinson's disease, I think based on these results, we can suggest the reverse, but still it's very complicated. I think we cannot draw a conclusion very specifically based on my results to how to apply tDCS in a clinical population. But it seems that with the case of tDCS, which is a weak and diffuse electrical field, actually the after effects are converted. But I am not sure that we can apply it directly, these results, to the clinical field.
Yeah, it's a bit, for the motor system, I think it's a bit tricky also because they have reduced intracortical inhibition. Also, we reduce GABAergic activity with tDCS. So it's a bit tricky to foresee, and there are not too many studies which have been conducted. I think most of the studies with anodal tDCS of the affected size, some showed some improvements of motor symptoms. It's a bit more clearer for cognitive symptoms, maybe, where there are, as far as I remember, a couple of studies doing anodal tDCS over the prefrontal cortex, which also makes sense because their D1 receptors are more prevalent. They are activating the glutamatergic system also, and which is important for diverse cognitive functions. And there they showed improved performance. The important thing seems to be also, and this is not only valid for tDCS but also for other brain stimulation protocols, that you are required to do the stimulation during the on phase. Because if they do it as an off phase, they don't show much plasticity. Okay, that then I think covers also the next questions from James Hopper a bit. Have you looked about patients with Parkinson's disease? So we didn't do this in our we didn't do this in our protocol. But there are some studies where they have done this. Okay, so I just saw we unmuted Dr. Harper. So if you want to add some questions or some remarks, please feel free. Okay, if there are no other remarks, then we have a question from Anufri Bose. Anufri, if you want to pose your question.
Hi, thank you, Professor Nishi. So I wanted to understand that how do you expect, because most of the antipsychotics work on are dopamine blockers, right? So how would you expect schizophrenia patients to respond to tDCS? I'm talking about the montage where we give anodal tDCS to DLPFC and cathodal tDCS to left temporoparietal junction.
Yeah, so Elham, do you want to say something? Otherwise I can.
Yeah, as far as I know, dopaminergic medication that we use in schizophrenia and in combination with tDCS, in schizophrenic patients, we saw also an abolishment in the after effects of tDCS. But about the montage, I think Professor Nishi can explain it better.
Yeah, so it's in general, I think so what you will have in schizophrenic patients without medication, some kind of dopaminergic overactivity. The antipsychotic medication aims to somehow to normalize dopaminergic activity. So if this works well, it's relatively difficult to. I wouldn't say that this overactivity would then or medication. Or it's difficult to foresee this simply conceptually, because this antipsychotic medication should have a normalized function. Healthy subjects, we know that classical antipsychotic medication, and especially those who have predominant effects on the two receptors, abolish tDCS effect. So if you get to a hypodopaminergic state in healthy subjects, you get exactly what you get in Parkinson's patients. In the off state, you don't see plasticity response with tDCS, but also with other non-invasive brain stimulation techniques. There was a study in schizophrenic patients where there was a retrospective analysis of the kind of medications these patients got. And what was shown there retrospectively is that patients under classical antidopaminergic medications, so which primarily affects the two receptors, indeed has had less therapeutic effects as compared to patients under atypical antipsychotics, which are not so predominant for the D2 receptor. This does not mean much, I think, for the electrode montage at the end, where for auditory hallucinations, negative symptoms, most of the studies have done left DLPFC combined with left temporoparietal junction, which worked relatively well in most studies. And this has so far not been systematically evaluated if some other electrode montages might be more or less efficient than this electrode montage.
Sure. Thank you so much, Professor Nishi. So do you suppose that then having, maybe running type of antipsychotic medication and their dosage as a covariate when we are looking at tDCS response as outcome would be a good idea, and maybe more trials should incorporate this?
I think that's important indeed. Yeah, I could imagine. I mean, also based on this retrospective data, that the specific combination of antipsychotic medication with tDCS might have an effect. And we see, for example, in our basic studies also that when we predominantly affect D1 receptor, D1 receptors with pharmacological interventions, we see different effects of tDCS. So we don't see the same as with L-DOPA or with D2 receptor agonists. So there might be specific effects, and I think it would be important to explore this more systematically in future studies. Agree completely. Yeah.
Sure. Thank you so much. Thank you so much.
Many thanks. Okay, many thanks, Elham, again. And now we go on with Ali Salehinejad, and he will tell us something about the impact of chronotypes and daytime of application on tDCS effects. So another, this one non-pharmacological neuromodulator.
Okay, can everyone hear me?
Yes.
But
We hear also some other guys in the background, whoever this is.
Noise, yes. Okay, I think now I can start.
That's fine, yeah.
Great. All right. Good time, everyone. Sometimes it's in Australia. It's actually midnight. I think it's actually good for my topic because it's about chronotype and time of day. So the previous speakers talked about the pharmacological agents and modulatory effects on cortical excitability. The topic of my talk is about the chronotype and time of day dependent effects of tDCS on cortical excitability. So nothing to disclose. And before we start, I just want to talk a little bit about my background because I think this is fun sometimes. I born in Shiraz in Iran, and it's a cultural capital of Iran, but I think the next speaker wouldn't agree. You can just Google it. So these are some pictures from the city that I grew up, and where we are also known being lazy. Most of the time people sleep, but I don't agree. Anyway, but that time currently is very bad time, because if you go there, you will definitely sleep most of the time. Anyway, so I did my bachelor in psychology and child psychology, and after that I joined the clinical psychology program in University of Tehran. This was where I officially started to be uh, part of the brain stimulation. And after my clinical psychology, I did a cognitive psychology, another master, and now I am doing my PhD in the Leibniz Institute with Professor Nietzsche, and I'm few months to complete the project. And the title of my project is The Impact of Circadian Factors on Human Brain Physiology, Neuroplasticity, and cognitive functions. Okay, let's go back to the topic. What is chronotype? So it is defined as the circadian preference. Circadian rhythms affects all of us every day. It's a 24-hour cycle, but some of us could have circadian preference. It's a kind of individual difference which has natural variation in humans. Also, recently it's been shown that the wide and broad genetic foundations. So basically the definition of we have three type of chronotype, but mostly we know that two type. It's morning type and evening type and neutral type. People who are morning type usually are most alert in the morning and enjoy waking up early and go to bed early. And the evening types are actually opposite. They are most alert in the evening, enjoy sleeping late and go to bed late. And so in order to have an idea how this is distributed in the population, so this study shows that it has the distribution of chronotype has a normal curve distribution. So which means a large number of us are affected. And a recent study also, which was conducted on US Americans on more than 53,000 participants, shows that this is also following the same normal curve. And if you look back to the previous slide, you see that most people are normal, but we have some slight early chronotypes and late chronotypes here. So what is the relationship of chronotype to our field, which is non-invasive brain stimulation? So I think most of us know this paper, which is about the factors that could affect the neurophysiology in the non-invasive brain stimulation. So one of them, which is not very well studied, is time of the day. And I think the chronotype is quite related to this factor. Besides the other factors, we have some biological factors and also some interindividual factors. There is another paper which also shows the factors that have impact on variability of non-invasive brain stimulation results. Because one of the topics, all of us know that some people say, okay, this technique does not work, this technique works, or the results are variable. That might be true or not true, but the thing is that there are many factors that we have not investigated systematically. Unless we don't do a systematic investigation, we cannot have an idea about the efficacy of these methods. So chronotype also is related to arousal level. So if I'm morning type, I'm most alert in the morning, and also my attentional states are in the morning more focused. And as I said, it has some genetic factors as well. So let's go directly to this study. And the topic is the impact of chronotype and time of day on motor cortical excitability, neuroplasticity, and learning. So some studies have shown that chronotype or circadian rhythms have effects on cognitive functions, brain physiology, and brain structure even. But the impact of chronotype on the specific parameters that we are mostly interested, like excitability and neuroplasticity, is not systematically investigated. So this was the motivation and rationale for doing this experiment. In this experiment, which is done, I recruited 32 healthy participants and divided them into two groups of early chronotypes or morning types and late chronotypes or evening types. So you will hear these two words a lot during this lecture. So just remember that early chronotypes means morning type and late chronotypes means evening type. So usually you can define the chronotype by a questionnaire, and based on your scores, you could be categorized either in the intermediate, which means neutral, or moderate or definite evening, or moderate or definite morning time. So I think we recruited more than 260 participants, completed this questionnaire, and based on that, we just recruited 32 because there are not too many people in these two categories. And here is the procedure of this experiment, which was quite long. So for each participant, first we measured cortical excitability at 2 times in the morning. Just want to clarify that all of the times in the morning and evening were same and fixed. In the morning, the time of measurement was about 8 in the morning, and in the evening was about 7 p.m. So first, all of the participants' cortical excitability was measured by TMS protocols like CK-ICF, I-wave facilitation, input-output curve, and short interval inhibition. All of them were measured 1 time in the morning and 1 time in the evening. The next part, which was about neuroplasticity, each participant attended 6 tDCS sessions, 3 times in the morning and 3 times in the evening. And we applied tDCS protocol, 1 milliamp per 7 minutes, and then measured the MMP up to 30 minutes. So, which means that so far they had 8 sessions, and they had the last 2 sessions. In the last 2 sessions, we also measured behavior and cognition because they wanted to see if there is any effect of chronotype on excitability and neuroplasticity, and if these two are associated with behavior and cognition as well. So here again, each participant attended 2 times in the morning and evening. So let me just go quickly to the results. First, I want to present my cortical excitability results. I think one of the attendees asked about CK-ICF for the previous lecture. So here I want to show the results of chronotype on cortical excitability. 2 protocols. We had more protocols, but I just present 2 protocols. The first one, this is IO curve or input-output curve. It is a measure of cortical spinal excitability. So we know from previous studies that IO curve reflects glutamatergic activity at higher intensities, which means here. So our results in this graph, in the left side graph, show that people at their circadian times had higher corticospinal excitability. So this is the graph for morning types or early chronotype. They had higher excitability in the morning and low excitability in the evening. And the reverse pattern was true for late chronotypes. Here we can see that the evening types had more corticospinal excitability in the evening, but not in the morning. We also used another protocol, which is short interval cortical inhibition and intercortical facilitation. I think most of you are familiar, but there are different ISIs, and the ISIs of 2 milliseconds and 3 milliseconds reflects inhibitory cortical inhibition, and the ISIs 5 and 10 and 15 milliseconds reflects cortical facilitation. So here again, the results shows that people, morning types, they had lower cortical inhibition in the morning, but higher cortical facilitation in the morning. I think it's better to put it this way. In the evening, the cortical inhibition was higher. In the morning, the cortical facilitation was higher. And exactly the same pattern was observed for late chronotypes. So you can see actually, Yes, they had more facilitation in the evening and more inhibition in the morning. So this is the first part of the results, and so this basically shows that the motor cortical excitability is dependent on chronotype. So if this is true, then in the next step, we wanted to investigate the effect of neuroplasticity induction with tDCS, because we know these neurotransmitters like glutamate and GABA are involved in the after effects of tDCS. So as I explained earlier, every participant attended 6 tDCS sessions, 3 times in the morning, 3 times in the evening. Here is the results of early chronotypes. So you can clearly see that people who were morning types had higher or stronger anodal tDCS induced motor evoked potential in the morning, and cathodal tDCS induced motor MMP in the morning as well. They also showed MMP in the opposite time, but the difference is significant. Actually, the difference between MMP are significant. So this shows that morning types had higher induced tDCS induced neuroplasticity at their preferred time. So we can expect that the other group show the reverse pattern, which is true. Here the late chronotypes show higher induced anodal tDCS neuroplasticity and cathodal neuroplasticity in the evening, but not in the morning. So in this part, we also, I think these results are in line with the previous one, because it shows that both groups had higher cortical facilitation at the preferred time, and now this was reflected in tDCS results as well. So basically, the summary of these two parts is that the glutamatergic related cortical facilitation and GABAergic cortical inhibition are associated with stronger anodal and cathodal tDCS induced plasticity at the preferred time, which means if you are morning type, your brain is more excitable and works better actually. And sometimes if we get variable results in tDCS studies, maybe it's because the people are not at their best time. Okay, the next part. How about behavior? So far we found that cortical excitability and neuroplasticity are affected by chronotype, but is there any association to behavior? In order to answer to this question, we used SRTT, actually it should be SRTT, which is a motor learning task. I think probably know the task. In this task, it's a serial reaction time task. You should respond to some stimuli as quickly as possible. It has 8 blocks, and in 2 blocks, in all of the blocks, the order of the stimuli appearance is follow a sequence, but in 2 blocks, which is block 5 and 7, the order is random. So the difference in the reaction time between block 5 and 6 reflects motor learning. So previous studies from our group also show that tDCS effects modulates motor learning on this task. So all of the participants did this task 1 time in the morning and 1 time in the evening while their EEG was recording. So here is the results. As you can see again, at behavioral level, the results also followed the same pattern. Morning types had more or stronger or better motor learning in the morning, and evening types had stronger or better motor learning in the evening. And interestingly, and this is about the error. So in this task, our primary outcome variable is reaction time, but we also found significant results in the number of errors, which means that people significantly committed more error when they were not at their best time. But importantly, we had the association of the ERP correlates. So early chronotypes had higher amplitude P300 in the morning on block 6. So block 6 is where the order of the stimuli is actually the difference between block 5 and 6 reflects more motor learning. And so we found here that morning types at block 6 had higher P300 amplitude in the morning, and the evening types had a similar pattern in the evening. So, and these differences were significant. So again, this shows that the better model learning at the preferred time was associated with the electrophysiological correlates. Okay, so let's go to some concluding remarks. We found that with regard to cortical excitability, there is higher corticocortical and corticospinal excitability at circadian preferred time. And for neuroplasticity, we also found a stronger LTP or LTD-like plasticity induction at circadian preferred time. And these two were also associated at behavioral level. So motor learning was also better at the circadian preferred time, and the electrophysiological correlates also supported this. So what are the implications? I think maybe the most important one is for our field is that it could partially account for variability in the non-invasive simulation results. If we don't get good enough results, maybe they are not in the participants are not at their best time. Maybe we should screen them for chronotypes, and maybe we should also fix the time of the testing. So another thing, another important implication is for clinical application. We know that in a specific disorder like bipolar spectrum or ADHD, they usually have some circadian rhythms problems. For example, in ADHD, which I study a little bit about. So these people usually are evening type, or I mean, the distribution of chronotypes in the evening. Maybe the treatments in the evening is more predictive than application in the morning. And the other implication is for working environment and schooling. We can ask our government to let us go to work late if we are evening type, or also our advisors if they're here. So thank you for your attention, and I'm here open for some questions.
Okay, so many thanks for this presenting this nice new data. We have a couple of questions here. Can start with Dr. Baker, who posed the first question, and just unmute.
Yes.
Oh, we have Dr. Cunningham now. Yeah.
Oh, can you hear me? Did you look at factors such as physical activity or caffeine consumption throughout the day between the two types, and how that might influence the results?
I'm sorry, could you say your question again?
I was wondering if you were looking at factors of physical activity or caffeine consumption throughout the day between the morning and the late types, and how that might influence the cortical excitability results.
No, actually, we didn't measure about caffeine intake, but there is another study in our group which measured effects of caffeine on the motor cortical excitability. In that study, we tried to screen the chronotype of participants to see if they would affect the results. But I think my results are quite preliminary and implicate that we can definitely do this in future studies that especially investigate caffeine or other pharmacological agents. But in this study, we did not.
But what we did do, I think, what we do as a general rule is that we tell them not to do strenuous physical activity up to 24 hours before our measures, and not to drink caffeine, not to drink coffee up to 3 hours before we do the experiments. So we didn't have people who were affected by acute caffeine effects or by acute strenuous activity in this study.
Okay, so I think I got the question probably wrongly.
So we didn't explore systematically impact of caffeine or something like this, but they were not allowed to have caffeine consumption a few hours before of our experiments. So we wouldn't expect an effect of strenuous physical activity or of caffeine on our results.
Yes, I think I didn't have time to explain, but we had a very strict screening. The participants should not have consumed caffeine. Also for the female participants, if they were in the menstrual period, which would affect the hormonal change, we didn't allow this. Anything that could affect on excitability, we tried to control, and the time was also fixed.
So if it's okay, I'll ask my question now.
Sure.
So I had two questions, actually. I might have missed this, but did you have a fixed preferred AM and preferred PM time? So for example, 7 AM was your morning, 7 PM was your evening, or did you make it patient specific?
No, the time was exactly fixed, and in the morning we start experiments around 8 AM in the morning, and for the evening it was started about 7 PM. So this was one of the challenging part, because sometimes some participants would come late, so we had to cancel it, but the time was fixed for sure.
Okay, and then my follow-up question was, did you also look at the effect of days of the week? So for example, I know I am not a Monday person, so I was just wondering if you looked at the days of the week as well.
No, this one we didn't check, but I think this could be interesting. One thing that we control, which might relate to your question, is that we control the time of the year, because in Germany the length of the day hours is quite different depending on the summer or winter. But we control that, but we didn't check the effect of a specific day of the week.
Okay, then we have another question of Dr. Bose.
Hi, thank you, Professor Nishe. Hi, Ali. That was a very interesting presentation. I have two questions. First is, what would you recommend for patient population who could be drowsy under the side effect of medication? How do we go about classifying their chronotype? It could be slightly tricky. Any recommendation you would like to make?
If I want to do a clinical intervention, I would, especially in the populations that have some circadian and sleep problems, I would definitely screen chronotypes and try to apply the intervention in the preferred time, because as the result shows, the cortical excitability is much more flexible in that time. But about the drowsy effects of pills and medications, so I don't know, but it's reasonable to think that if they are drowsy and not alert, if the intervention is cognitive based, probably they would affect, but I really have no idea on this part. But for sure, we should actually screen them based on the chronotypes and do and apply intervention at the best time as much as possible. This is what I would suggest.
Sure, thank you. And do you recommend a questionnaire or something for classifying chronotype?
Yes, actually, there are two famous questionnaires. One of them is Mohsen morning evening type questionnaire. But if you just Google morningness eveningness questionnaire, you can easily find it. We have also a free link at IFADA website. It's German, but you can use Google Translate. I mean, it would automatically translate it, and it can give you your results in 5 or 10 minutes. But I think it's freely available in some website if you just Google morningness eveningness questionnaire.
Sure, thank you so much. And just one last suggestion. Do you think if we were giving individualized tDCS to target certain symptoms, it would be ideal to take chronotype into account and then administer tDCS, therapeutic tDCS to the patient, depending on what chronotype they classify as?
Absolutely. This is actually one of the extension of this project. We wanted to see if this has effect on therapeutic intervention. So especially if they have a specific chronotypes, I would suggest to do them intervention at their preferred time.
Sure. Thank you so much. That was really helpful.
Hello, thanks for the presentation. I'm thinking about the influence of the sleep homeostatic process. Did you control for that, let's say the minimum amount of sleep that participants had the night before the experiment? Because I'm thinking that it's not unusual for evening types to be sleep deprived, and that may play a role.
Yes, actually, in the instruction form that we give them to the participants before the beginning of the experiment, we ask them that they should have enough sleep, preferably from 11 to 7 in the morning. And if they could not comply this, we would cancel the session, which we did several times. So yeah, we control that one.
Okay, thank you.
Okay. Many thanks again. I think we have to go on now. It's the next talk given by Mohsen Mosayebi, and now it's a titration study, stimulation protocol dependent effects of cathodal tDCS. So we go on now with methodological variations of tDCS.
Hello, Michael. Can
Yes.
you hear me? Yep.
I can hear you. Yes, everybody can hear you.
Okay, nice. Hello, everybody, and happy to have you here. Today, as Michael said, today I would shortly discuss about the stimulation protocol dependent effects of cathodal tDCS by focusing on our updated published work. Before I start going into detail, I should shortly say that wherever I use term of tDCS, cathodal tDCS, I'm referring to this specific electrode configuration, which is the main electrode over the skull targeting primary motor cortex, and then return or reference electrode over above the supraorbital area with the specific type of 5-7, and then the result are just for the young, healthy, right-handed, and based on the technique, MEP elicited TMS, which is an index for corticospinal excitability alteration. So, and then for the method, as my previous colleagues also presented, we measure the baseline first by applying single pulse and recording MEP. And then we apply tDCS as an intervention. And then again, with different time points after intervention, we measure MEP again by TMS MEP. And then we compare the peak-to-peak amplitude of MEP after and before to see the effect of tDCS. So earlier work of the tDCS showed that a stronger and or longer duration of tDCS might improve the efficacy of the technique, but later work add further complexity on this simple assumption. For example, by 1 milliampere cathodal tDCS for 20 minutes, they showed MEP reduction, MEP amplitude reduction, but by doubling the intensity, they see MEP amplitude enhancement. Or for example, by doubling the duration, for example, 1 milliampere for 13 minutes, anodal stimulation resulted MEP amplitude increase, and while when they double the duration, they see MEP amplitude reduction. So the main question for us was that, or the main motivation for us was that clinical tDCS have shown clinical promising result, but the overall efficacy of the technique is still limited. Okay, the question here is that what is the optimal protocol? To answer this question, in the first study, we manipulate different intensity and duration. Here, 1 milliampere, 2 milliampere, and 3 milliampere, each intensity 15 minutes, 20 minutes, and 30 minutes, plus sham. And the after effect, as I mentioned before, evaluated using the TMS MEP up to 24 hours with different about 14 time points. Our result indicated that 1 milliampere protocol mostly reduced the MEP amplitude for about 30 to 1 hour after a stimulation, while 2 milliampere protocol, 2 milliampere cathodal tDCS protocols enhanced or increased the MEP amplitude with 2 milliampere 20 minutes for about 2 hours after a stimulation, and 3 milliampere protocols again reduced the MEP amplitude with 3 milliampere 20 minutes, the most efficient dosage protocol, which was the after effect was about 2 hours after a stimulation. So generally we found a nonlinearity with 1 milliampere reduction, 2 milliampere enhancement, and again 3 milliampere reduction. And then one could explain this as a microscopic level is the calcium channel dynamic, which depends on the calcium concentration. We would see LTD, LTP, and no plasticity induction. Here, for example, we would argue that 1 milliampere protocol, 1 milliampere cathodal tDCS protocols induce LTD based on the low calcium channel concentration. And then when we increase the dosage or intensity, we would reach to a level with no plasticity induction. And again, for 2 milliampere protocol, we reach to a level of LTP. And then for 3 milliampere protocols, we would argue that this might be as a result of calcium overflow, and then a counter-regulatory mechanism bring the state of synaptic system back to the normal state. Okay, at the mesoscopic level, or we would say that back to animal study, based on animal study, it has been shown that different layer of cortex react differently to the anodal and cathodal tDCS. For example, in 1.1 millimeter depth, we see anodal increasing the firing rate, and then cathodal decreasing the firing rate. But in another layer, we see something different. For example, anodal stimulation decrease the firing rate. This might also somehow explain our result, in which electrical field as a result of low intensity and then high intensity react differently and activate different neural population. So the combination of this effect might explain our nonlinearity. And at the macroscopic level, also, it has been shown that tDCS not only affect at the local effect, local area, which is under the electrode, but also it has the global effect or network effect. This might also somehow explain our result. Okay, in conclusion, for this study, we manipulated different intensity and duration. We saw dosage dependency and nonlinearity, and we found with in our population with this specific protocol and electrode montage, we found this optimal protocol 3 milliampere 20 minutes. Okay, at the second study, back to animal study, it has been shown that repeated application of single intervention might enhance the efficacy of the intervention. And based on the result of animal study and then previous human study in our group, which they applied tDCS and testified single repetition of this tDCS protocol with short and long interval, short interval of 3 and 20 minutes and long interval of 3 hours and 24 hours. They showed that short interval could improve the efficacy of the technique, and long interval reduced the efficacy of the technique. Based on those results, we designed our second study. We used low and intensified dosage. Here, intensified was based on 3 milliamp per 20 minute protocol, which we found in previous study as a most efficient protocol. And low dosage here is 1 milliamp per 15 minute as a somehow a standard protocol. And then we used short 20 minute and long interval for both protocols. Our result indicated that for single intervention, which means that no repetition, we somehow found early LTD, which means that the after effect was in the range of about 1.5 hours, less than 3 hours. And then for short interval protocols, we found nearly unchanged in comparison with single protocols, no intervention protocols. And then for long interval protocols, we interestingly, we found the efficacy of the technique reduced, especially for high dosage, high intensity protocol, which we found it most efficient in a single intervention in previous study. So what can explain the result at the cellular level is that previous study mostly focused on NMDA, AMPA, glutamatergic, GABA, and other neuromodulator, but and calcium channel dynamic, but for the enhancing the efficacy or plasticity induction, other mechanism also work, like metabotropic glutamate receptors. This might partially explain the result. And another thing is that in repeated application of any stimulation, BCM theory also play a role in which first stimulation change the threshold of the system, and then depends on the and then depends on this first stimulation effect, the second stimulation effect will be changed. So in conclusion, for the second study, we tested single repetition of optimized protocol and standard protocol. Our goal mainly was to see if the single repetition of these protocols can induce late phase LTD, means that more than 3 to 4 hours. We couldn't find this, and we found that even repeated application of intensified protocol can reduce the efficacy. So as I told you, we just tested this result on healthy young human subjects, and there should be other studies. In future study, we should see if the result can be one-to-one transferable or not to the other age group, to the patient. And also we tested just on motor cortex, but they should be tested on other cortical area. I presented the effect of tDCS at the neurophysiological level, but we should also see if most efficient protocol that we presented here, we found here, can also work for functional effect of tDCS. Another thing is that we try to find the optimized protocol at the group level, but there might be a chance that using other technique, we try to optimize at the individual level. Okay, thank you for your attention.
Okay, many thanks, Mohsen, for showing these new results about optimization at the group level with modification of stimulation parameters. We have some time for question, but so far there seem to be no questions.
Perfect.
So if there are none, then I think we can go on with Desmond's talk now. Another titration study. Now there's a question popping up from Ela Pro.
Okay.
So question is about in patient populations, these dosage and duration factors have to be managed with training rehab as well. Any thoughts about this? Mohsen?
There is another question also. Okay, this is privately. Okay. In patient population, these dosage and duration factors have to be managed with training. Of course, I told you that I can just argue about my result on healthy human subjects, and then this should be also tested, and after that we can somehow argue. I would suggest, if I understand it correctly, I would suggest to before using a specific protocol, there would be it would be good if we can titrate different dosage for this. Yeah, this is my suggestion, if I understand it correctly, right, Michael?
Yeah, I think that's one part. Maybe just shortly, question might aim also to side effects to tolerability. So in our study, we did topical anesthesia with local anesthetics cream, simply to ensure also blinding there. But there are other studies. Mark George did a study some time ago, I think, published in Brain Stimulation, where they simulated its intensity up to 4 milliamp in elderly population, combined with motor training or with some task performance, and this was completely blinded, and they didn't have relevant side effects for this. So it should be feasible for the patients. For the 3 milliamp stimulation. This is what we didn't show now. Cannot be absolutely sure that since we have this 2 milliamp, we have excitability enhancement, that this is a secondary inhibition we get. And we did a study with calcium channel blocks, so we thought it might be due to antagonistic mechanisms due to calcium overflow, where you could revert the effects of 3 milliamp stimulation. So that's I think so far an open question. If you want to reduce excitability, you won't have this secondary inhibition, I think, at the end. So this would be something to explore more closely in future, I think. Well, that's my little part for it. And there's another question now about depth of the target we want to reach with tDCS. Are the effects the same, whatever the depth? 1 milliamp reduce, 2 milliamp increase. And yeah, let's say we observe the effect in the insulation instead of motor cortex.
Yeah, actually, based on the modeling studies, since this is the DC current, the electrical field distribution will be same for different intensity, but the electrical field distribution, but not the magnitude of electrical field, means that when we use 2 milliampere, in ideal situation, the electrical field in a specific time, a specific location, will be doubled in comparison with 1 milliampere. And for 3 milliampere will be 3 times more in comparison with 1 milliampere. Means that then it can be speculated or it can be argued that the neural populations that did not activated or did not activated with 1 milliampere might be interact more to the tDCS effect with 3 milliampere and or 2 milliampere because of receiving more electrical field in that location. Based on Samuel, this is the answer of this question, I think, as far as I could answer.
Okay, many thanks. Many thanks again. And we come now to the last talk given by Desmond Agboada about titration of anodal stimulation.
Okay. Can everyone see the slides?
Yes.
Perfect. All right. So my colleagues have done enough justice to the introductory portions of tDCS. So I will not bore you with so much details about the introduction. So my name is Desmond Agboada, and I'm working in Michael Nietzsche's lab, and I will present to you today some of the experiments I've conducted over the last 4 years in the lab on stimulation protocol-dependent effects of anodal tDCS. So over the last 2 decades, there's been so much work done on tDCS so far, especially with the montage that Michael Nietzsche discovered in 2000. And that is the left motor cortex and the contralateral supraorbital montage. And this was one of the first titration studies of tDCS. And in this study, Michael increased the dosage of intensity from 0.2 up to 1 milliamperes and found a linear relationship between the current intensity and the induced after effects. And these induced after effects were measured by TMS induced MEPs, or motor evoked potential, which my colleagues have spoken about into quite some detail. And following up with that original study, he conducted another one where he showed that with increasing the duration of stimulation, you can increase the duration of the after effects. So another linear dose response relationship for the duration of stimulation. The story, as we are finding out over the last decade, is a little bit more complex than the original, what was originally found. Now, the good thing about tDCS is that it is tolerable, and so there has been a lot of application in the clinical use. And quite recently, in one very important paper by Georgi Batiskade, who was a Michael student, he found out that beyond 1 milliampere of current intensity, the dosage and then the after effects, the relationship is not linear, and that the relationship is actually partially nonlinear. Following up with this, Asif Jamil in Michael's lab conducted another titration study. Here, he looked at a bigger parameter space, so from 0.5 milliampere to 2 milliamperes. And so for these 4 current intensities, if stimulated with 15 minutes duration, he found out that all these 4 intensities enhance cortical excitability as measured with TMS-induced MEPs. This is what you see in the left panel of the figure. Also, at the same time, Sarah Tremblay I believe from Canada, also conducted another titration study, which Asif and Sarah arrived almost at the same conclusion, that for another tDCS, within the parameter space of up to 2 milliamperes, you will see that there is an enhancement of cortical excitability, but there is no significant differences between these intensities. So the story, as I said earlier on, is complex, and this probably could be because there are so many factors that influence the after effects we see for tDCS. And it could be participants related, it could also be the stimulation characteristics or the experiment that is designed. Ali spoke about the time of day and chronotypes. So one issue of variability, as is being discussed in the field right now, could actually be a result of we conducting the experiment at the wrong time of day for the participant. So in fact, we do have to optimize all these parameters to be able to get a protocol that can be used irrespective of participant or irrespective of the clinical population or healthy population. As Michael have said yesterday and continues to say, it is quite difficult to design an optimization study that takes into consideration all the possible factors of tDCS parameter, because I mean that is just impossible. So for my PhD, I focused on only the intensity, the duration, and then the interval of stimulation. So these are stimulation specific factors, because one reason, irrespective of the participant and the kind of experiment you do, you will always need this stimulation specific factor. So it is very important that we design optimization studies or titration studies that can, in a way, optimize these parameters for possible clinical application. So as I said, I concentrated on these three factors. And if you can see the figure, intensity and duration combination, this is what we do all the time. And for single session stimulation protocol, all we need is to vary the intensity and duration. But then this only gives us, for the most of the time, an early RTP-like plasticity. So the plasticity that is induced based on this single session protocol is always within maybe 1 to a maximum 3 or 4 hours. But if we want to increase the duration of the induced plasticity, we might have to consider other techniques or protocols, which in this case could be a space stimulation protocol, where we stimulate after, and then we wait for some time, and then we stimulate again. And in this, we could probably induce a longer neuroplasticity. So the interval is also important when considering stimulation-dependent factors. So the general aim of these two experiments are conducted was first to titrate intensity and duration of tDCS to obtain an optimized protocol. Here, by a very crude definition, an optimized protocol is the protocol that induces the best neuroplastic effects. So the protocol that induces a longer effect and then by size, a bigger effect. And then in the second experiment, I looked at if this so-called optimized protocol can be compared to a standard protocol, which is basically a protocol that has been used for the last 20 years and which we are quite sure about the effects. And I did this by comparing the interval. So there was no repetitions, that is the single session. There's a repetition of 20 minutes or of 3 hours. So this is the first experiment where we look at if intensity and duration affect the different combination of intensity and duration affect the neuroplasticity that is induced. And here we used the common, or what we say, the conventional protocol of 1 and 2 milliamperes. And then we expanded the protocol, the parameter space by moving up 1 notch to 3 milliamperes. So we have three intensities, 1, 2, and 3, and then 3 durations, 15, 20, and 30 minutes. So these combinations gives us 9 different conditions, and then compared to a sham protocol. So we found basic, so the baseline, cortical excitability, we induce neuroplasticity with our protocols, and then we measure the after effects up to the next day evening. So here, this is the result of our first titration study with another tDCS. You can see the figure A, B, and C. So these are the intensity domain 1 milliampere, 2, and 3 milliamperes for the durations of 15, 20, and 30 minutes. As you can see, for all 3 intensity domains, you can see there is an increase in cortical excitability for all of them. And you can see a similarity in the after effects induced by all these 3 intensities and 3 durations. But if you look carefully at the third figure, you can see that 3 milliamperes, which is the more intense protocol, induce slightly higher cortical excitability compared to 1 and 2 milliamperes. So these trend-wise superior effects we found for the intensified protocol shows to us that this is, in this study, the most the optimized protocol. So in our conclusion, we've been able to, in the experiment 1, to expand the parameter space of another tDCS up to 3 milliampere, and then with durations up to 30 minutes. And we found that at the group level, there is similarity in effects induced by these 3 intensities and 3 durations. We also found, as I said earlier, a trend-wise effect of increasing effects when we increase the current intensity to 3 milliamperes. In the second experiment, what we aim to do, as I described in the beginning, is to be able to induce late phase plasticity with our optimized protocol. Now, this is very important for tDCS, because if we aim to use tDCS in the clinic, for example, and of course for cognitive enhancement, we will have to aim towards a longer duration of neuroplasticity. As you can see on the left side, this is a picture from Principle of Neuroscience, the Cathodal textbook, which illustrates how early and late LTP plasticity is mechanistically produced. So for early LTP-like plasticity, we found that calcium influx via MNDA and AMPA receptors, which combines with calmodulin, and then in a long biochemical process with protein kinase C, leads to phosphorylation of new AMPA receptors, which potentiates the synapse for quite some time. So this is an early LTP. But for a late LTP, there is a transcription of protein, which occurs in the nucleus. So after calcium enters the cell and combines with calmodulin, there is a further upstream biochemical process which brings about gene transcription, which produces more effectors that are able to produce new AMPA receptors at a higher rate, and are able to make these AMPA receptors available for a longer potentiation. So we have late LTP in this scenario. Now, this was tested in humans using a tDCS. So in this experiment, Montesilvia showed that if you apply tDCS, here she used 1 milliampere of another tDCS applied either within 3 minutes or 20 minutes for the short interval, or 3 hours or 24 hours for the long interval. Now for the no repetition, so tDCS applied 1 milliampere, another tDCS applied for 30 minutes. We found, that is the first figure, figure A, we found an increase in cortical excitability that lasted for close to 1 hour. in the repetition, when this duration was doubled, so when 30 minutes was doubled to 26 minutes, there is a reverse of polarity of after effects. So instead of an enhancement of after effects, we see a diminution, which clearly shows that if you keep increasing the duration of stimulation, you keep stimulating for a long duration, you might not be able to enhance further. So there will be probably a saturation of the system, which demonstrates the reason why space stimulation might be preferable to just elongated stimulation. So for the figure C, where there is stimulation for 30 minutes, and then after that there is an interval of 3 minutes, we see that there is an increase in cortical excitability. And when there's an interval of 20 minutes, also there's an increase in cortical excitability that lasted up to the next day evening. Now, for the longer duration of interval between stimulation, we found a diminution of after effects, which shows that for you to induce late phase LTP-like plasticity with space stimulation, the interval is extremely critical. With a short interval, you can induce a late phase LTP-like plasticity. But with a longer interval between the stimulation, you might not be able to induce LTP-like plasticity, late phase LTP-like plasticity. So this is what I tested in the second experiment. Here, I compared the optimized protocol, which is the intensified protocol from experiment 1, with a standard protocol, and the standard protocol of 1 milliamp per 15 minutes, which we know that the after effects are about 30 minutes to 1 hour. So we have a single session stimulation, and then we have a short interval stimulation of 20 minutes, and then a long interval stimulation of 3 hours. So after effects were measured by TMS-induced MEPs every 5 minutes after 30 minutes, and every 30 minutes up to 2 hours, and then up to next day evening. Now the results here were quite interesting. We found that for both the intensified optimized protocol and then the standard protocol, for the single application of these protocols, we find both protocols induce LTP-like plasticity, but this was an early phase LTP-like plasticity. We see clearly an enhancement of after effects up to 30 minutes, which came down to baseline after 1 hour. Now, when the stimulation was repeated within a short interval of 20 minutes, we found that both the intensified and then the standard protocol as induced LTP-like plasticity. But here, only the standard protocol, which is 1 milliamp per 50 minutes, was able to induce the late phase LTP-like plasticity. The more intensified protocol was not able to induce late phase LTP-like plasticity. It only induced early phase LTP-like plasticity, which was up to about 120 minutes post-stimulation. For the longer duration, for the longer interval, we found that for both the intensified and the standard protocol, there was no late phase LTP-like plasticity. For the standard protocol, we can see a slight enhancement of cortical excitability. But for the intensified protocol, we see a complete diminution of after effects. So one explanation of this could be that, so we know that LTP-like plasticity is glutamatergic, and it is based on NMDA receptors and AMPA receptors. So of course, within this time frame of ELTP, we are sure that the effects we see are based on calcium dynamics in the glutamatergic system. Now, for late phase, as I explained earlier, for late phase LTP-like plasticity, there must be gene transcription, and which, in our opinion, is the reason why we are able to see a longer duration of after effects when we have a shorter interval of stimulation. Now, one other explanation could be the famous synaptic tagging hypothesis by Riemann and Frey. So here, they argue that with a short interval between the first and the second stimulation, you can be able to induce late phase plasticity because there are messenger RNAs that capture a synaptic protein, and within this short time are able to transport this protein to other synapses for potentiation. So the short time is extremely important. When the time is longer, then of course these captured proteins are not able to be transported to other synapses that need to be potentiated. Now, of course, as has been said earlier by Mohsen and other colleagues, calcium overflow by Leishman is also another possible theory to explain why with the more intense stimulation, so with a higher intensity of 3 milliamperes, we were not able to induce a late phase LTP-like plasticity with a repetition, because perhaps the increased intensity or the higher intensity increase more calcium at the synapse, and this calcium overflow could lead to a counterbalancing effect, that is by opening more potassium potassium gates, which of course with more potassium coming into cell, which decreases activity. So here we've been able to induce early phase LTP-like plasticity with both the standard and then the intensified protocol. And we found out that repeated stimulation with a short interval, we were able to induce late phase LTP-like plasticity. But with a long interval of 3 hours, we were not able to induce late phase LTP-like plasticity for both protocols. We found out that for late phase LTP-like plasticity, it is best if the interval is small, that is about 20 minutes, and if the intensity is less. So with a more intensity, you might not be able to induce late phase LTP if you use space stimulation. So in the future, we will have to see, so this experiment was conducted in the motor cortex. And one thing we will have to look at is how does the other cortical areas respond to this space stimulation protocol. So we will have to investigate that by transferring this protocol perhaps to the prefrontal cortical area or the visual or the parietal cortical areas. Of course, we will have to see how this novel approach of inducing late phase plasticity interacts with cognitive tasks and other behavioral applications. Thank you very much.
Thank you, Desmond, for showing these new results for anodal tDCS, which might result also in new application protocols with prolonged and intensified stimulation. I think we are a bit tight now with time. If there are some questions, we can maybe fast answer them also. So we can unmute Anushree. There's a first question.
Hi. Thank you for the interesting presentation, Desmond. It was, the findings were quite thought-provoking. I would like to know, you recommended intensified protocol, say 3 milliampere for clinical application. Yes. So in your experience, how does that fare for tolerability? Because for therapeutic purpose, sessions are often given twice a day and for extended period of time spanning several days. Yeah. So what do you think about it?
Very good question. So in the paper, which would come out in the next couple of weeks, we showed that even with a higher intensity of 3 milliamperes, it is tolerable, even with repeated stimulation. So the first experiment, which was published in Scientific Report, we also showed that with single application of the high intensity, it was tolerable. So obviously, there are side effects of tDCS, which are minor. So redness of skin, pain, all those are minor and they disappear within a few minutes, up to maybe 30 minutes after application. But in your question, you are more looking at the repeated application. So maybe in the clinic, you are applying every day for so many number of days. Yeah, I can only speculate because I've only done this with healthy population, and we know it's a little bit more complex with clinical population because we have to look at so many other factors. So of course, their underlying condition and every other thing is different. But I can speculate that, of course, because we found 3 milliampere intensity to be safe and tolerable with healthy population, it most probably would be in clinical population as well.
Sure,
Maybe.
thank you. Just one quick question.
Yeah.
For, how many repeated sessions had you given?
So only one repeated session. So
Okay.
yeah, so we didn't have 2 or 3 repetitions because of obviously
Sure.
based on animal experimentation, just one repeated session is better.
Sure. Thank you so much. Thank you so much.
Thank you too. Michael wanted to add something.
Yeah, maybe should add that in our studies for blinding purposes, we combine this with topical anesthesia.
Yeah.
So, but there are studies in old stroke populations from Mark George's group who've shown that 4 milliamp was with these subjects when they conducted a task also during stimulation was well tolerated, so there were not really side effects. Could speculate that this might partially depend on age, partially also depend on that they were, of course, not attentive too much to stimulation in this case. If it's better in patients, the stronger stimulation than weaker stimulation, especially when you combine this with rehabilitation techniques, is something which has to be shown, I think. So we see gradually better effects on plasticity when you apply it alone in healthy subjects. If you combine this with other protocols, I would think what it shows to you, what these results show to you, is that for inducing long-lasting effects, stronger stimulation is not always better, and that systematic titration studies would make also sense at the group level in patient populations. So for the numerical results, then it has really to be shown that if this translates one-to-one to patient populations, which that's speculation. So we need, I think also in patients, we need more systematic studies with regard to this. Okay, so there were, Desmond, there were a few questions about when the paper is available. I think the first paper, the titration paper, this is already published, it's available in scientific reports.
Yeah.
For the second one, this will come through brain stimulation. It's accepted now, it will be fully open access, so it will be in few weeks. I think it will be available also via PubMed and so on. Okay, and Mohsen just sent the link in the chat. Many thanks for the scientific report paper, I think.
Yeah.
Right?
Thank you, Mohsen.
Okay. So if there are, for now, no more questions, we are also a bit longer than we originally planned. Many thanks for attending, all of the audience. Good times of the day, not so good times of the day. I think we showed you interesting results about how you can adjust tDCS effects based on stimulation parameters, based on daytime when you apply the stimulation, but also how this stimulation interacts with pharmacological interventions. Many thanks for attending. I think if there are questions in future, we are always happy to answer emails. And many thanks to my PhD students who did a great job, I think. And yeah, have a nice day, have a nice evening, have a nice morning, wherever you are. And yeah, see you soon, hopefully, I think maybe next year at one of the conferences. See you soon also physically then. Many thanks. Bye-bye.
Bye-bye. Bye-bye.